Warm good morning to all. Now I welcome you all to the newer topic, cerebral visual impairment. CVI or cerebral visual impairment is a deficiency in the function of vision due to damage in the brain. This is due to damage or malfunction of visual pathways and visual centers in the brain, specifically those posterior to lateral genital body, which may be accentuated by associated disorders of the control of eye movements. It's a newer topic and it's not included in our PG curriculum also. So when such children come for assessment, we are in a dilemma. How to do justice to these children? So in our IC, what we are planning is initially pathophysiology and spectrum of disease, and then how to do a functional assessment. Then our experiences in our Trichure Medical College and then at Palakkad District Hospital, how we run these clinics, and surgical management of CVA, the comorbidities. So now I invite the first speaker, Dr. Mallika, Professor of Ophthalmology in Trichure Medical College, to give the talk on vision and brain, understanding CVA in children.
Good morning, one and all. Thank you, Dr. Geeta, for giving me this opportunity. My topic is Vision and Brain, Understanding CVA in Children. By definition, CVA is the verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairment. Why the CVA is becoming important in India? Because it is emerging as one of the commonest causes for visual impairment among children in our country, maybe because of with improved management and survival of preterm babies, children affected by brain injury due to perinatal insult, metabolic disorders and trauma. And there is the need for multidisciplinary approach for management in specialized, and it is very specialized and it is very challenging. If you check the epidemiology, the incidence is 36 per 1 lakh in late 1980, but it is 161 in 2003. So if you check the Indian scenario, this is also not much different. And the Indian study also shows that the prevalence of CVA is similar, and also it is very similar in children belonging to the rural population and the urban population. If you check the Western data and the Indian data, the main causes for visual impairment in children is almost the same. Now, we see how does the brain see. We all know the visual pathway, the stimulus starting from the object to the eye, and how does it reaches the retina, and through the visual pathway to optic nerve and the optic radiations to the lateral geniculate body and then to the occipital cortex. And what happens when the image reaches the brain? That is important. There are three important stations where it is conveyed and it's interpreted. One is the station 1, that is the occipital lobe, and the second station is the posterior parietal lobe, and third station is the temporal lobe. So this is the information passes from the occipital cortex, then and in the occipital cortex it is interpreted visual acuity, the color vision, the field, etc. The information also passes to the next area, that is the middle temporal lobe, which is the area of visual attention, and then it also passes to the temporal lobe. This is considered to be the library of the visual system, where the images of the different objects and persons which is being stored. So whatever objects we see, and we will match these objects with the images stored there, then interpret, oh, this is that particular person, this is that particular object. All these are taking place in a very slow process, and at a conscious level. Then information then passes to the posterior parietal lobe. This is the area of visual attention. Suppose we want to see particular object in the midst of so many objects, this area comes into play. This area acts in relation with the other parts of the brain, like that is the frontal brain, and it has association with the motor area, sensory area. Suppose we want to take an object from the table. In the table there are so many objects are situated. Suppose we want to take a particular object and we should think of it. What should be the distance I should move? And what is the acceleration I should take, and want to take particular object, that is decided by this area. So that is the importance of this area. And there are two streams. One is the dorsal stream, that is otherwise called ver stream, that is in concern with the location, movement and spatial orientation of visual pathway. And the other is the ventral stream, that is otherwise called Watt stream, that is concerned with the color, texture, pictorial detail and the visual memory. So what are the causes of this CVA? Major causes the hypoxic ischemic injury in the perinatal period. If it happens in the full-term neonates, that will result in watershed infarction in the parieto-occipital region and the parasagittal area. If it is in the preterm neonates, that will result in periventricular leukomalacia. Other mechanisms are oxidative and inflammatory damages that will lead on to death of immature oligodendrocytes. These are some of the etiological factors. One is the this meningitis, especially due to herpes simplex and bacterial infections, and head trauma that will lead on to posterior cerebral ischemia and subdural hematoma. All can lead on to venous sinus thrombosis, thrombophlebitis, hydrocephalus, hypoxic ischemic insult to the watershed areas. And there are certain congenital malformations like Chiari malformation, encephalocele, meningoencephalocele, and hydrocephalus, posencephalic cyst, and hydrancephaly, Dandy-Walker malformation. All these are supposed to be the causes. CVA in late child are due to melas-ornithine transamelase deficiency, Fabry's disease, Leigh syndrome, X-linked adrenoleukodystrophy, respiratory arrest, head injury, complications of cardiac surgery and cardiac arrest, focal infections, etc. How do these children present? They can have mild visual loss and to the total or near total blindness. So ocular findings are refractive error. They can have hypermetropia is more common. They can have strabismus, exodeviation is more common, and they can have nystagmus, and that implies coexistent anterior visual pathway involvement or onset of visual loss before the age of 2 years. And tonic down gaze and horizontal gaze palsy, all these are very commonly seen. And the other common findings are optic disc hypoplasia and pseudoglocomatous optic atrophy like findings. To conclude, the eyes just see, but the brain visualizes. The knowledge of complex visual processing in the brain helps better understanding of CVA. So every ophthalmologist should have a basic knowledge and aware of CVA. Thank you so much.
Thank you, Dr. Mallika, for the lucid presentation. Now I request Dr. Samyukta Sadashivan, Assistant Professor, Government Medical College, Thrissur, to talk about her perspective of CVA, that is an ophthalmologist. Thank you.
Good morning, everyone. From where Madam has stopped, I'll be continuing with a small presentation on the ophthalmologist perspective of CVI. So what is the primary role of the ophthalmologist? To establish a diagnosis of CVI after a comprehensive eye examination compounded with effective counseling, which sets ground for further management. So how do you diagnose CVI? When the visual performance of the child does not match with the ocular findings, especially when there is a history of a neurological ailment or there is an eventful perinatal period. Think of CVI when the parents complain of variability in visual performance. They say that the child sees at times, sees better at times and not at other times. They also say that the child is not able to establish any eye contact. There is a limited or a fleeting visual attention, that they use more of proprioceptive sensations to do tasks. They take more time to learn details of an object, that they have problems with eye-hand coordination, difficulty in recognizing people by seeing, or difficulty in understanding language of facial expressions, or in judging depth and distance. Always think about coexisting OVI also, ocular visual impairment, because congenital cataract and optic atrophy are frequent associations. Optic atrophy has been found to be associated in nearly 40% of cases. And there it is important to identify the cause for the optic atrophy also. So comprehensive eye examination follows. And examination, while we do an examination, we should think about two aspects. We have to check the visual function as well as functional vision. Both are different. So when we assess the visual function, you should, your routine examination protocol, like checking for acuity, contrast sensitivity, color vision, peripheral vision, and extraocular motility pattern, all these fall under testing for visual function. Now, functional vision assessment aims to ascertain the limitations of binocular vision in everyday life. So this is a very useful analogy they've made. The measurement of visual function is like measuring the feet, while the assessment of functional vision is like fitting shoes. So this is an entire list of behavioral patterns which we observe and make use of in understanding functional vision. So as is routine, we should document the head posture, if any, adopted by the child. As Madam listed, so many head postures are taken up by the children depending upon their disability. Congenital motor nystagmus, poor neck control, spasticity, all these things make the child adopt specific postures. Document them. Facial asymmetry is possible because of the underlying genetic or metabolic cause which is attributing for the CVI. And different ocular alignment patterns are noted. Note these. Vision assessment, you have to go for qualitative tests as well as quantitative tests. You can document these, whether the child is able to do a central steady maintained fixation, see if he is able to fix and follow objects, or if there is any resistance to occlusion. Quantitative tests, we have Lea grating, stellar acuity cards, Cardiff acuity cards, Lea symbols or Lea cards for testing near vision. These are the different methods of testing visual acuity, age-appropriate methods, modified after Hyvarinen in 2000. And remember, when you check visual acuity in children with CVI, higher contrast and background illumination may be needed to obtain reliable responses. Contrast sensitivity, we have Heyring-Heady low contrast tests, and visual fields, gross peripheral field can be tested by using objects of interest, like a familiar toy, illuminated or bright, which are brought suddenly in the periphery. This is Atkinson's et al.'s test battery for the assessment of functional vision and oculomotor functions. So many additional tests are also described. And we shall make it a routine to do a thorough anterior and posterior segment examination. ROP has been found to be coexisting with peripheral PVL, and pseudoglaucomatous optic disc with narrow NRR is noted in children with PVL occurring after 28 weeks. Refraction gives special stress. You have to do dynamic as well as cycloplegic refraction. 10 to 60% of children with CVI have significant refractive errors requiring spectacle correction. Suma Ganesh et al., they have done this particular study where they found that simple myopic astigmatism is the most frequent refractive error in children with CVI. And 57% of children with varying types and severity of cerebral palsy and 80% of children with Down syndrome have been found to have reduced ability to accommodate. How do we assess accommodation? We shall observe the pupil size while we do a dry retinoscopy. As the child switches attention from a distant to the near target, if it doesn't become small, if the pupil size doesn't become small, think of impaired accommodation. And if the retinoscopy reflects changes from width to against and the pupil becomes small, it indicates that the child can accommodate. Sometimes these children won't be able to cooperate for retinoscopy. You can have ready-made glasses of +3, +4, +5 diopter lenses, and then you can make them wear the glasses and look for the behavioral pattern. And both eyes converging on a near object again indicates that possibly the child is accommodating. Imaging has a definite role. These are the different category of pattern of lesions which we can expect in imaging. So the successful intervention known is spectacles in correcting the refractive errors and accommodation related problems. So, and this is something which requires mention. When you go for visual stimulation exercises in infants with CVI, make use of large, high contrast, lighted, reflective, moving objects in an uncluttered environment from different directions with variable level of light in the environment, and avoid overstimulation, and avoid these when the child is hungry, tired or frustrated. Special considerations while giving glasses: take into account the lack of accommodation, give the required add. And one more point is that appropriate spectacle frame adjusting to the shape of the skull should be chosen, because these kids would be using other aids like hearing aids also. So there should be space for accommodating those as well. And plastic lenses are safer, weightless, more comfortable. These are the issues related to the usage of glasses. Counseling is of utmost importance in these children. Always focus on the strengths of the children and empower the parents to modify the visual environment. We should give them necessary assistance in finding experts to control the systemic issues. And this is another thing which requires attention. Reports on the outcome of visual and cognitive functions should be sent to the pediatric neurologist and psychologist, and definitely to the teachers also. The parents and teachers should understand the outcome of such assessments to support a child with CVI. So it's basically a multidisciplinary approach, and it definitely works. Thank you.
Thank you. Thank you, Dr. Samyukta. And next talk is on CVA, the experiences from Government Medical College by Dr. Sujata. She is additional professor in ophthalmology, Government Medical College, Thrissur.
Good morning to all. I thank KSOS and Dr. Geeta for the opportunity. My presentation aims at sharing our experience in starting a CVA clinic at Government Medical College, Thrissur. My interactions with Professor Dattan during the CVA workshop I attended was inspirational and was in starting a CVA clinic. And practical hands-on experience I got from the CVA clinic of Palakkad under Dr. Geeta was also of great help. Started jointly by the departments of ophthalmology and pediatrics, our clinic started functioning on the January 9th of 2023. It is attached to the Regional Early Intervention Center and Autism Clinic, which works or functions at the OP annex of our medical college. Word above Regional Early Intervention Center, it's a team of pediatricians, various therapists like physiotherapists, speech therapists, psychologists, psychotherapists, and social workers who are working under the Social Security Mission of Kerala. They have many functions and programs, of which I think the most important or relevant to us is the early detection, intervention, and management of children with development delays. So our clinic attached to the Regional Early Intervention Center adopts an interdisciplinary approach. That is, a child with CVI may have other problems. So all the services the child requires is got under same roof. And there is communication and interaction between different departments so that a proper or the ideal strategy can be, intervention strategy can be selected. So this is what usually happens in the intervention center. A child with development delay is first seen by the pediatrician who assesses the systemic condition, rules out any motor, sensory or any intellectual issue, and refers him or her to the CVA clinic where we assess the visual functions. And there are certain children who come directly to CVA clinic. So after our evaluation will be seen by the pediatrician also. Though sharing the same floor as the pediatric OPD, our clinic is in a sheltered and quiet corner. There is plenty of space in the waiting area, and walls are painted neutral white, and effort is taken to provide a clutter-free environment. Though you see so many of our apparatus for testing, all are kept inside the table and taken only when necessary. And there is also provision to change the ambient lighting of the room for children who work better in the scotopic conditions. So this is our approach for a child who comes for evaluation, who comes to our CVA clinic. First, we take, after recording a detailed history, we do a medical record evaluation to understand the condition. Then we move on to the visual assessment. So we also make the parents of the children fill up a validated CVA inventory in Malayalam. So there will be some children who are not seen early by any ophthalmologist. Such children, we do a detailed anterior and posterior segment evaluation. Then in all children, we assess the power of accommodation and also do a refraction assessment. Then, as she said, we move on to vision assessment. Visual acuity assessment is usually we take the age-matched test, and in young children, we prefer the Lea paddles, which make use of the forced choice preferential looking principle. Then contrast sensitivity, which is very necessary to have a to establish a basic data and to know the working distance, is tested by hiding AD test, and then we get a basic idea. Then field of vision is tested usually by Lea flicker wand, and here you can see that the child only is interested to look only in the superior fields. Then how well he uses the vision he has, that is basically the dorsal stream function is tested to rule out any optic ataxia, that is visually guided movement, how he performs well in this field. Then whether he is able to match shapes and colors, that is tested by the Lea puzzle. Then whether what is his understanding of the perception of orientation by Lea mailbox. Then we have converted a part of our clinic into a visual stimulation area where such activities can be demonstrated and carried out. Then our optometrist is trained in CVA. So she visits the high risk NICU twice a week and tries to pick up children with high risk for CVA. And they are asked to come to have an early appointment where we can administer early intervention. So these are the services we have right next door to our clinic. We have the medical officer's room, then clinical psychologist who can assess the IQ in older children and also counsel the family. And then speech therapist. So here our idea of vision can be also communicated to a speech therapist so that she can work better. Then also physiotherapy and also occupational therapy is carried out. So here the second picture, the child with suspected inferior field is trained to climb down the stairs. Usually if posterior parietal lobe lesions, there will be an inferior field defect. Child finds it difficult to climb down the stairs. This child she doesn't have an absolute field defect, but some neglect is there. So what is important is that a child who is coming for CVA assessment can also have their physiotherapy appointment and speech therapy appointment, whatever is needed, on the same day. And providing all services under one roof is appreciated by parents of our patients who are usually from a low socioeconomic group. This is our profile of patients. We have screened 43 patients with CVA. of which the commonest etiology is, as usual, is similar to the literature, hypoxic, ischemic, and encephalopathy. Then age of presentation varied from 2 months to 7.5 years. Number of low-functioning CVA patients is alarmingly high. That is one of the major problems. And that is also one of our challenges because CVA therapy is very difficult. The child with a low-functioning CVA has other problems also. So it is very difficult to motivate them to start, continue, and maintain therapy. Then there is one thing. We only saw 4 patients with high-functioning CVA. That is, are we missing out children with high-functioning CVA? So, well, should we screen children with trivial insult like an episode of hypoglycemia or epilepsy for these features? And there is another big group of patients who come later, much later, with learning problems to ophthalmology. And such patients, are they having severe characteristics? Should we screen them? So this is because we had a child who came to us at 5 years. He has started schooling. He's because I have videos, but I can't show them because they have not allowed. The mother took the child to our clinic for learning. He cannot copy anything from the board. And so when we examined, we found that he already was seen in the pediatric OPD 4 years back. He had a stomy and in a postnatal period. And he was advised frequent reviews, but he did not turn up. Now, when he has started schooling and there is problem there, they have come. Somebody suggested CVA clinic and came to us. Then, when we examined, we found that he cannot recognize his own face in the class photo. So this temporal lobe affected. Also, when we gave balls to play, he cannot play football. Is the posterior parietal lobe part affected? We don't know. We are working on that. So that is all. We are in an infant stage. We only 10 months. We hope to improve upon it. I stop my presentation with special thanks to our RAIC team and also Dr. Geeta for the encouragement and support. Thank you all.
Thank you, Sujata Madam, for that. Now, let us hear from Dr. VKP Geeta Madam, who has been carrying forward commendable work after establishing the CVI clinic in 2019 in Palakkad DH. She would be speaking about her experiences from health services.
Good morning to one and all. Special thanks to KSOS Scientific Committee for including this in the IC and all the participants. Video. Okay, this is, so you have heard so much about CVA. I just want to share 2 case studies. This boy is a premature baby. The first one, it was a premature baby who had a very stormy neonatal period. And he is having neonatal convulsions also. He is unable to recognize his mother, no eye contact. You must have seen his face is, there is no expression, there is no social smile. So that is low functioning CVA. Now this is, sorry, previous. Okay, this child, play. Okay, mouse. This child, he is coming from the school who is branded as learning disability. The parents are saying he's clumsy and intelligent but not performing well in the school. So that is their complaint. So when we were doing the assessment, this is Leah puzzles, he was unable to recognize the shape, size and direction. So this becomes very important in studies. So that is also CVA. So at one end of the spectrum, we have a child who cannot see, very low functioning CVA without eye contact and poor visual acuity. Whereas in the other end, we have high functioning CVE with almost good vision, but clumsy and unable to learn. So these two pictures you should keep in mind to understand the spectrum of CVA. Common in all this is eye is normal, the impairment is due to cerebral pathology. Now the definition they have told the CVA is a verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairment. That is latest definition by Saki. And low vision is not a typical feature of CVA. Almost 60 to 70% of children with CVA have visual acuity better than 6/18. So, in our country also the CVA is increasing. A recent study from Hyderabad, LVP, Dr. Niranjan Pehre and Gordon Dutton, they have shown that under 3 years of age with severe visual impairment, 33% had CVA and 11% had CVA plus OVA. So it is alarmingly increasing. Why we need a special clinic for CVA? Actually, these CVA children, when mentioning about the clinical features, Dr. Samyukta has mentioned, they have a variable vision. The dictum is the vision may vary in different situations. So, in the busy OPD, in the visual clutter, their vision will collapse and they may not cooperate also. And we need more time, patience and skill to examine them. And to evaluate them, we require special tools like Leah gratings, hiding Heidi, etc. And usually they have multiple disabilities and may require special seating arrangements like CP chair and all. So, this a clutter-free space where you have ample time and relaxed atmosphere is needed for a CVA clinic. Now, I just want to share my experience, how we started our clinic. We had started ROP screening in 2015 and was doing this follow-up of premature children, vision assessment and all. And while doing the assessment, once one mother brought her child, around 2 years child, was lying, it's a CP child. She asked me, Doctor, എൻ്റെ മോൾ എന്നെ കാണുന്നുണ്ടാവോ? I was shocked and really didn't know what to answer. And that question haunted me for quite a long time. And maybe I just was thinking how to help these children. And meanwhile, I got an opportunity to attend a national level training on vision assessment and pre-verbal children. That was done by Dr. Leah Hyvaran. She's very passionate about CVA, assessment of CVA and training. So from her, I got so many guidance and like even after the training, we could communicate over mail, and she was very helpful. And slowly we picked up, and I contacted Dr. Dutton also by mail, and he was also very, very helpful and encouraging. So with these guidances, we started one CVA clinic. It was inaugurated in 2019, maybe the first one in government setup at WNC Palakkad by Sri M.B. Rajesh, the MP then. Actually, he took keen interest in this project and arranged sponsors, without which we could not happen. Because it is not in the government sector, it was CVI, the concept. Now NHM has taken up this concept, but still we are struggling because of lack of funds. And we were privileged to attend the national training on CVI in 2019, conducted by, organized by NHM, and Dr. Linda Lawrence was the trainer. Dr. Parvati, who attended the training, is here. And another optometrist is our REAC optometrist. Now, the advantages of being in a government multidisciplinary hospital. That is, always NICU support is there. You know, the high risk babies you know, and they will come to you for assessment. And then always pediatric support is there. And DIC, District Early Intervention Center, as Dr. Sujata mentioned, that is a nodal center. That is the ideal place, because we have all these people there. So you have a physiotherapist, we have a special educator. So vision has a pivotal role, and you can share your information, how much vision the child has, that you can share with the other people, other team members, like physiotherapist. Because if the child is having inferior field defect, he will not be mobile. He will not keep the leg and on the floor because he cannot see. So it's always a teamwork. When to suspect high functioning CVI? We all know low functioning CVI will come to you because he will behave like blind. But in high functioning, they will go to school because they have near normal vision. So when the child has difficulty in reading, writing on basic arithmetic, and when the child appears to be clumsy, when the child has short attention plan, then problems symptomatic of lower field defects, such as difficulty in climbing the stairs, and some children will not like crowded places, like that. So in such situation, you should roll out high functioning CVA, like in learning disability. Some from school, people will come, will be referred as learning disability. See, their intelligence may be normal, but they cannot recognize shape, size, etc. And that may be the reason for their poor performance in the class. And this Dr. Samyukta has mentioned everything. Behaviors typical to children with CVI. So I'm not going into the details. A child with CVI, like in low functioning CVI, the child may become aware only when surrounded by a tent with nothing else to see. That situation is very, very tricky, because child will behave like a blind child. And another concept is looming. Fast moving things may not be seen or may appear to be on collision course when actually they are not. And the child may scream and will get frightened with no reason. And the parents will be alarmed. They'll be wondering why the child is behaving like this. And another important thing is eye contact may be abnormal. So in the school, the teacher may say, see, look straight. Like that the teacher will say. And the child cannot look up and say the answer. Both together he cannot say. So what we train the child is, we tell them that you just look up and then turn your face and then answer. That is possible. Then the teacher is also happy, child is also happy. Actually, child usually has less than 1/3 of 60 to 80 visual processing functions. Every child with CVA has their own unique pattern of vision. Every single component is affected in different proportions and different degrees in every single child, like a kaleidoscope. Our aim is to find and know the limits and staying within them using alternatives extend the limits. The approach is a transdisciplinary one. Then first thing is whether the diagnosis of CVI, then any ocular problem is associated with CVI, then that should be dealt with, like cataract or strabismus or refractive errors. Then counseling. Counseling is a very important part, because you should tell the parent that only if you know how your child see, you will be able to help the child by arranging required environment. And another thing is you can give a concept about neuroplasticity also, like the neurons fire together will wire together. This is a history. For history, we do taken this Dutton's inventory and translated to Malayalam. Evaluation part is in visual acuity, refraction and dynamic retinoscopy all should be done in this CVA clinic. Okay, this is dynamic retinoscopy. Video previous. See, this child, when we visited a blind school for a camp, from there we picked up this child. Actually, he's some 10 or 11-year-old child. He had autistic features also. See, he's a case of Balin syndrome with optic ataxia, simultanagnosia, and dorsal stream dysfunction. When we assessed, we could make out that accommodation lag is present. So we gave a +3 glasses. See how he is managing now. He's seeing this. This is another girl with spastic diplegia. It was very difficult to assess this girl, but with great difficulty we could do the refraction, and it was -8, and that is why she was streaming. And after giving correction, she's very happy. So the moral is the most cost-effective intervention in CVA is spectacle correction. The functional vision assessment, most part is dealt by Dr. Sujata, Leah Gratings, Hiding Heidi, then visual field assessment. All these should be tested. And Leah puzzles for cognitive function. Now in very low functioning CVA, where the child cannot even have visual awareness, then you have to keep the child in a monochromatic translucent tent to eliminate the surrounding clutter. Then enhance the attentional capacity and enable him to utilize the limited vision. And show a illuminated toy in dark room with auditory or tactile elements. Because when the vision is weak, you should have both the other parameters to have a strong, memorable response. That is multimodal stimulation. Then light pad activities. So coming to the visual intervention, what we are doing is, it's not a passive one, it's an interactive approach. Instructor chooses specific stimuli, making adjustments in assessment while looking at the reaction of the child. And this should be carried out within the context of major developmental activities. First thing is helping the child to use the vision, and secondly, helping the child to understand what is seen. Then strategies are like when lack of vision on one side, you can have you can make the child to sit on one side of the classroom and rotate the plate to see the food and all. Lower field assessments, I mean impairment, then you can keep the floor clutter free, and you can use white shoes, like that. Depending on the problem, you can have the strategies. And it's always teach the child to be, it's okay to be different, atypical. The three key rights for children with CVI is right to learn, right to independence, and right to effective social interaction. CVI can be very disabling but trainable. With right training at the right time, their skills can be enhanced. This is a success story. A profound CVI girl who was diagnosed at 9 months with congenital ESO. She was operated by Dr. Sanita, and now she's almost normal, going to school. At this juncture, I would like to extend my sincere gratitude to my mentors, Dr. Gordon Dutton and Leah Highwarner.
Thank you, Dr. Geeta, for their wonderful presentation. Now I invite Dr. Sanita Satyan to present topic on surgical management of CVI.
Thank you, Dr. Geeta, for giving me an opportunity here. I'll be talking about surgical management in children with cerebral visual impairment. So what makes it different in a child with CVI? So we know that they have a primary ophthalmic pathology along with their own disability-specific challenges, which makes it very difficult to manage these children sometimes. The first and foremost thing which I would like to talk about any child with CVI is when you have counsel for the surgery and the patient is first meeting the anesthetist, a thorough preoperative assessment is mandatory. You have to do a thorough systemic screening. You have to do a cardiac echo. That is, sometimes all these children may have even syndromic cases, will have some associated cardiac problems. Parents may not have realized that. They might tell you that she's all asymptomatic, no problems. But that has to be thoroughly screened. Always take a cardiac echo to rule out any anomalies. Get a fitness from the pediatrician, cardiologist, neurologist if necessary. And most of the children, they come with their MRIs and all those features. And that has also to be taken into account. Many have seizures because of this HIE induced problems. This has to be properly attended to. Their renal status, sometimes an abdominal ultrasound, all these may be required when you look into children with this cerebral visual impairment when they are going to surgical procedure. During anesthesia, always anticipate a difficult airway intubation. So you should be prepared, whether you do with a ET tube or IGL, doesn't matter, but you should anticipate any difficulties and be prepared for that. Like this child with a low receding chin, and this is a case of difficult airway intubation. And also some children have a large tongue because of the syndrome associated or some hypothyroidism also. So the anesthetic should be looking for all these things. And associated seizure disorder has to be managed because most of these children, they will be on drugs, and then when you're they usually they have sometimes if you have a controlled seizure for 6 months or so, you might very well go on with the surgery safely. Sometimes you might need a loading dose also prior to the surgical procedure. and we can always expect a delayed recovery from anesthesia. So don't panic, they will recover, but delayed recoveries are also common. Post-op care. Post-op care is very important in these children. Surgery done, and it's very difficult to manage any child after surgery. When you have a special child, pain management has to be adequate. Like for a strabismus surgery and all, I usually give analgesics for 2 or 3 days, after which the patient should be okay. But CVI child, you have to attend to their pain, maybe analgesics for some more time. Parental counseling is very important, and always they have a aspiration risk, so they can develop pneumonia, so you should be able to prevent such problems post surgery, and they have more risk of infections also. And one thing I would like to tell you is that most children, see, after bilateral strabismus surgery, some people have we might patch both the eyes for some time. So for a CVI child, it's very alarming. Like if you're closing both eyes after surgery, the child is not getting any visual input. So that might create a lot of havoc in the recovery room. So I usually don't patch them. You have to prevent eye rubbing post-operative. All that is okay, but at least use shields so that they will be very sure of their environment in which they are when they recover. And different conditions, this congenital nasolacrimal duct obstruction is very common in children with syndromes, especially Down syndrome and other associations. So you are giving a short GA, but you have to take all the precautions for a proper GA, because this is a little risky procedure, and then it's not as simple as it seems. And punctal stenosis is common in children, so you have to have the dilator ready, different sizes, and the risk of repeat procedures has to be explained to the parents. And congenital cataract, again, this is a very important thing, because you need to, usually we calculate IOL power for adults preoperatively. In children, especially with those with special needs, we may not be able to do it preoperatively. So IOL power calculations are done under GA in the OT. So you have to keep your staff and equipments ready for that. You will need to keep a inventory of IOLs. You usually follow the normal normograms. And primary posterior capsular excess with anterior vitrectomy is done in almost all the children, whether CVI or not. But I would like to say, in those children with CVI who are grown up, there also those who fall out of the preview of a PPC also, we generally do a PPC, because that is always safer to prevent a PCO formation and repeat procedures. We use self-absorbable sutures, because suture removal is going to be another GA. And this is a situation in which bilateral sequential cataract surgery can be contested. But again, I would, if the risk of GA is not that severe, I would always prefer to do one eye first. And strabismus is rather common in children with developmental delay, and esotropias and exotropias are seen. They can have any kind of squint, vertical squints, all those are very common in these children. Because of multiple factors, the results of a strabismus surgery are less predictable in children with developmental delay, because of the, I don't know the cause, probably because of tone of the muscles, accommodation problems, and all those makes our surgery a little less predictable, and normograms need to be optimized. So we have a small data on that, which says that patients with CVI had significant undercorrection than controls. So this has to be taken into account when you do your surgery for children with CVI. And all the oculoplasty procedures like entropions and ectropions are common. One problem with them is that eye rubbing is a very difficult thing to manage. So chances of recurrence has to be explained. Trauma and infections, this is another problem, because all these children with some have head banging and seizure disorder. So the post-op management becomes really difficult. You'll have to operate again and again with GA exposure, multiple surgeries. The post-op care is a nightmare, and also a great financial and economic burden to the family. All this said and done, children need post-op rehabilitation with refraction, spectacles, and their integration into a proper education system. So one thing before I conclude, I would like to say is that, see, most children with CVI or special kids, they do have a lot of exotropias and a lot of squints. And there is some amount of parental pressure on the ophthalmologist to do surgeries, because mother doesn't like a child with a big exotropia walking around. Child is not looking onto the face, eye contact is less. So they'll ask, doctor, can you correct with this with the surgery? You should do surgery, but always counsel them, because see, autism is not a disease, it's a visual perception disorder. Children with autism can have CVI, but you doing the surgery and correcting exotropia is not going to solve all their problems, but the expectations may be high. So this kind, I'm associated with National Institute of Physical Medicine and Rehabilitation, where I do the CVI clinic, and there a lot of people come around with this kind of questions. But as ophthalmologists, we should convey this clearly. Again, when you do a surgery in a child with exotropia, the advantage is that binocularity is much better if you do an early surgery. But again, that is a questionable thing in children with special needs. So all this said and done, each child is special. That's why they're called special children. So each requires different kind of approaches. Consider the parents, mothers, while doing surgery. So I'm concluding, there is a higher prevalence of ocular problems, proper precautions, especially during the GA and post-op period, and consider the holistic profile of the patient and caregivers before attempting surgery. Thank you.
Sorry, we don't have time for a question answer session. Hope everyone have some idea about CVA, and thank you for patient listening.